Healthcare in senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential.
So I'm very glad to have you guys here today. So I'm joined by Segue Health. Joe is attending to a high needs patient right now, and so we got to get invited to or got introduced rather to Segue Health within the last couple months. And you guys are a transitional care practice, and so I wanted to just kind of talk about a couple of stats that I was able to pull. The most recent stats that I found are out of Florida, but they're close enough. They kind of mirror our population here in Texas. And according to the Florida Quality Improvement Organization from 2023, roughly 18.4% of seniors are readmitted to the hospital in the first 30 days. And other studies show that 11.1 are readmitted within the first 2 weeks. And we always tell patients all the time, like your first 7 to 10 days are usually the most crucial, because if you think about it, even if it's a single site of care, so we go from home to the emergency room and then through the hospital, even without going to a rehab facility or a skilled nursing facility, there's usually a medication change. There's a new diagnosis that's in there. There's confusion with those kind of things, and so that first 7 to 10 days is is like the most challenging time for the family there and the patient. And it's the time where we see the majority of the bounce backs. And there's now penalties for American hospitals for bounce backs within those first 30 days. So I have with me Eric Auger, who's the state director for Segue Health of Texas, Sarah Rourke, one of the lead for nurse practitioner for Texas, and Amanda Whitmire, who is the state director for care coordination. All right, awesome. And you guys started out of Tennessee, correct, Eric?
It was based out of Memphis, Tennessee, and it expanded into Mississippi first. We started doing some hospitals down in the Mississippi area. And then it grew into Tennessee. And then about 4.5 years ago, Steve Clark, our executive director, wanted to open up Texas. And he and I had worked on some other projects before. And so we've been in Texas for a little over 4.5 years now. Okay.
And the whole purpose of this is the transition back home, it doesn't matter what type of facility, whether it's an acute care hospital, a rehab hospital, or
Correct.
A skilled nursing facility. It's to help make sure that there's I don't want to say seamless, but a better transition. That's why it's called transitional care.
Sure.
But a better transition away from acute case or facility-based care, where you've got nurses and therapists and doctors running all the time. So now you're back home, and we got to figure out how to make this work here without all the attention.
Well, if you think about it, most of the people that we're seeing are elderly.
Yeah.
And they're getting their diagnosis is sometimes for the first time of heart failure or COPD.
Yes.
There's a lot of things going on. So obviously we've all been in the area where we've seen patients in the hospital, and trying to listen to discharge orders can be very, very confusing.
Yes.
So part of what we're doing with our care coordinating team there in the hospital, we're trying to actually help them understand that discharge order.
Yep.
And then transitioning them from the hospital to the home with a nurse practitioner, who, the best way I like to talk about it is like they're going home with the hospitalist from the hospital.
Yeah. Because
the hospitalist is the one writing all the discharge orders and what needs to happen next. You need to go see your PCPs or specialist. So our nurse practitioners, like Sarah, is taking those notes and then transitioning that patient to a little bit smoother transition to the home, and where they're not having to remember everything. Just let us kind of be that air traffic control once we get into the home.
There you go. Yeah, they've done some studies that I'll point out. One was out of the Journal of Gerontology. This might have been a year and a half ago. And they said that upwards of 2/3 of patients, geriatric patients coming out of a hospital, experience a decline in their functional status. So the ability to perform activities of daily living or instrumental activities of daily living. So we're already coming home with a level of frailty they're not used to having. And there's been some studies on delirium where up to as many as 50% of seniors going through an acute care hospital system will experience delirium. And there's a portion of those that have longer term effects coming home. So relying on them to remember all their discharge instructions. And I'm sure you guys see discharge instructions for the hospital all the time. It's a book about like this thick, and it's not printed in easy to read language. And it's not like, hey, here's the top 3 things to do. It's no, we're going to give you 87 million things to look at and read, and which just creates more confusion. So another reason to have somebody else in there kind of quarterbacking the care at home.
Yeah. And the important thing is that we're not trying to take the primary care's physician's role. Yeah. We're just here to assist them so that we can go get that patient into their office as quickly as possible.
Yeah.
You know, because many times, many primary cares don't even know that their patients are in the hospital. And so we're trying to help the primary cares as much as we're trying to help the patient kind of get that coordination of care back together.
Yeah.
And one other thing, a lot of people might think that we're home health. We're not home health. And you might want to be able to express what home health does versus what we do. But we kind of team together. When you're having a nurse practitioner working with a nurse from the home health agency, now you've got a great team, because then you can come in with your OT and the PT and just really bring the whole community resources together.
That's right. So Sarah, what are some of all the diagnoses that you guys see coming out of hospitals, what are some of the most crucial ones that you guys these definitely should be ones we should consider for transitional care?
So definitely congestive heart failure and our COPD patients for sure are our top 2. And then like sepsis and, falls and the injuries that come with that, but definitely CHF and COPD.
Okay. Because they're being discharged stable, at least at that point. But because they've had a recent exacerbation or a recent new diagnosis, it's kind of crucial to make sure you guys are there to help make sure that, the weights aren't going up too fast. Yeah. They're paying attention to their diet, that kind of stuff.
Yeah. And just to get their medications, a lot of them, either forget or they don't want to go get them, or they're not taking them right, or they're taking too much, or they don't have the equipment they need, like a scale or a blood pressure cuff. Right. So it's just kind of hitting all of that and making sure that they have everything they need. Yeah. In those first few days, so they don't end up right back in the hospital. Those
of us that work in like the home environment, so you guys too, we always tell like facilities, like the home setting is invisible to everybody else that doesn't go there. And so, we can make assumptions, about compliance with medications, but until you actually see how they're doing it at home, you have no idea that they're doing these things. So I think it's really important to have you guys out there, especially on the medication side. And we were talking before on, you guys are looking at social determinants of health, and it's not even beyond that, the spiritual needs too. So talk a little bit about what that looks like.
You want me to speak on
Either
that?
one.
Okay.
Yeah.
You'll go ahead. I'll follow up with you.
Well, yeah, we, all of our patients, we do social determinants of health and just try to figure out where are the gaps, like what do they need? What socially do they need? And just trying to fill that in, whether it's going to get medications or going to get, buying equipment for them. We have a ministry fund so that we can help with that and just meet that need, because some of them have $5 to last them 2 weeks till they get their check, and they can't go afford a $40 copay for a medication. So we can go get it for them and bring it to them.
Wow.
And, and just witnessing to them, showing them, that someone loves them and cares for them, is a huge part of what we do too.
Oh, for sure.
Yeah, we have a full ministry team up in Memphis that can help do some end-of-life counseling when needed.
Okay.
We many times pray with the patients there in the home if they're wanting that. We never really push anything, but we do just simply say, hey, before we leave, could we pray with you? And Brian, you'd be amazed how many patients say, yes, please with me. And, and there's not a particular religion that we're pushing, but we are given an opportunity to live out our faith right in front of them, because so many people are thinking about, just what's happening to me and I need some extra help.
Yes, absolutely.
You'd be amazed at how close that brings you to the patient. Like just opening that up to them.
Oh, for sure. So I told you guys earlier that I had a disc injury, a pretty severe one a few weeks ago. And somebody in the healthcare space actually prayed with me over the phone unexpectedly. And I had tears because of how touching that was to have somebody do that for you. So I totally get that. Yeah. And I'm a little convicted that I don't do that myself right now, but maybe we need to change that one. What are some examples of patients, like we talked about some examples of diagnoses, but are there stories that kind of ring out? They're like, hey, had we not been there, we would not have caught this.
Yes, for sure. You want me to go?
Yes, please.
So actually just like 3 days ago or Friday, I had a patient who went home on with heart failure. He's like, has a new life vest on. They had just upped his furosemide, and he had an old dose of it. And we were like sorting out these medications, which are like, some are here, some are in the kitchen, some are in the bedroom. And we finally got them all together. He's like, I just don't feel good. I'm so dizzy. I'm weak. Well, we pulled them all out. He was taking 3 times his dose. He was taking his old prescription and his new one, and was like tripling his dose. And I'm like, that's why you feel terrible, And so had we not been there and like sorted out everything with them and actually like took the time to bring it all together, we wouldn't have found that, and he would have ended up on the floor or, just like totally dehydrated and worse kidney failure, know.
Oh my gosh. Eric, sounded like you had one of those stories too.
I can remember one out of one of the hospitals we were seeing in the South area, the Dallas-Fort Worth area, where there was a patient that had a COPD, and the hospitalist was ready to discharge, but come to find out that the patient had trouble with their air conditioning in their home. And so through our ministry team, and we were able to go in and put a window unit in the home. And that helped them be able to, for that hospitalist to say, okay, let's get that patient home. At least they know that they're doing well.
That's incredible.
Yeah.
Yeah. Especially here in Texas.
Yes. And it was right in the middle of the summer. So he was not ready to discharge her until something happened because they couldn't get the AC fixed in her apartment. So, but just some of those things where we're able to extend our care past the clinical. We're reaching the holistic part of the patient, not just clinically, but what are areas besides just from a Sarah Rourke to what Amanda's group can pick up there at the hospital. That's how we found out about it, is through our care coordinators in the hospital.
Okay.
That they relayed that information to us. So then we were able to go into action and take care of that patient.
That's a great segue.
Yes.
That's correct. So tell me, the care transitions team, you guys are in hospitals, majority of them, or several of them around here, and you guys are there throughout the day doing bedsides, coordinating with the social workers, case managers there. Kind of walk me through what that looks like. How do you guys get connected with patients? What kind of things are you gathering, information are you gathering from the case manager, from the patient, from the POAs, families, to make this a seamless transition?
Yeah, sure. So we have care coordinators in all of our hospitals for the most part, and our job ultimately is to meet the patients at the bedside and to find out what their home environment is, like what their demographics are. Do they have everything they need for discharge? So how that referral comes about is that the case manager communicates that with us. They send us the referral, and then that's our cue to go see that patient at bedside before discharge. Yep. And ultimately, what we want to do there is get to know them on a personal level, because that's very important to have that connection to bring in a nurse practitioner to that patient's home. We have to build trust before they let us in. So we're trying to identify anything that may be a barrier for discharge. And if we find out certain things like they can't afford medications, they can't afford DME, they may not have electricity or food at home, we're able to problem solve that while they're in the hospital. So they're ready for discharge when they're ready to go home. And we relay that information to the case manager so that way we can better assist their transition.
I bet that is golden for them, because I know, we meet with case managers all the time, and they are constantly pressed for time. And the fact that you guys are kind of being an aid or an assistance to them in identifying even stuff like, food insecurity, living situation, what's the caregiver support look like at home? I bet that is a huge selling point.
That's why we partner with hospitals. So, obviously we can't just walk into any hospital and have a care coordinator in a hospital and do that. But when we do partner with the hospitals, that's where they see the benefit of having Segue part of their team of case management, because now the case managers have a resource right there with them through Segue to say, okay, now they feel a little bit more comfortable discharging that patient, sometimes even a little bit earlier, because if they're able to get that patient well enough that can actually help impact their length of stay at the hospital and kind of start reducing not only readmissions, but over a period of time, we can help that hospital partner reduce their length of stays there as well.
Oh, sure. Yeah. Like effective case management can help them because they're paid by DRGs and days. And
that's correct.
The faster that, I shouldn't say it that way. There's a financial incentive to stabilize patients and get them to the next care setting, whatever they might be. Right. And I can definitely see how you guys can
and our partnerships with our hospitals are at no cost to the hospital. So I wanted to just bring that out in case there is anybody out there that might be looking for some partnerships with us. We would love to be able to at least have a conversation with them. Because we can show them how we can just partner right in there and slip right in there with them.
So you guys help on the care transition side through your group in terms of helping like on site with case managers to help prepare for a better discharge. But so that's one piece of like the value that you guys bring to hospitals, but it's also reducing ultimately their 30-day return to acutes, which is correct. For those that aren't aware, there's penalties associated. I don't know the math on it. I don't run a hospital, but I'm very much aware that we're sensitive to 30-day readmits. And so that's really like on the financial piece of it, you guys can help with the care transition side, getting them out a little bit faster because we're being more effective there, but also, and probably more importantly, on the back end where it's like, let's keep them out of the hospital longer. So I know we talked about the stats are like 18.2. I've seen them actually higher than that too, but 18.2 for seniors going back in the first 30 days. I've seen them closer to mid 20s. What is Segue's return to acute?
We average over a year period of time anywhere from 9 to about 10% on readmissions. And that's throughout all of our hospital systems that we're a part of. And obviously that goes up and down throughout the season of the year. Obviously we're getting ready to go into the fall. So we expect to see a little bit higher returns sometimes for some things. But here's what we know. The quicker we can get involved with the patient, and the more frequent we can have those touches, the greater chances we're going to be able to keep that patient out of the hospital.
Yes. Well, I would imagine too, it's not really a one-to-one. When the Florida Medicare puts out these readmission stats, it's kind of this global picture.
Sure.
If I'm a hospital and I'm choosing to work with Segue, I'm probably selecting the most critically ill ones that I know I'm going to need help with.
Sure.
So you're probably not getting your Parkinson's ones going home. It's going to be the really sick ones, with CHFs or COPDs or sepsis or whatever. These are sick people that I know I'm going to need some additional hands in the home. I'm probably not going to send you the easy ones.
Sure.
And so it does kind of influence those numbers. So even considering this, the level of acuity you guys are seeing, 9 to 10% is incredible.
Yeah. And like I said, seeing them early in the hospital and then seeing them frequently afterwards is what helps the hospital system. And so there's several benefits. Obviously to the hospital, we're helping them drive down their readmission rates for them. So it's a financial, it's a big thing for them. For the patients and the patients' families, we're there to help bring a lot of comfort from that clinical side, trying to help define all the things that are in those discharge orders. Yeah. And then on top of that, the spiritual need. So many people need, whenever we're able, again, just to go in that home and help them. And sometimes Sarah can just have just a simple conversation, just the conversation alone brings a lot of healing in and of itself. But then it opens up the doors to find out what are their other needs.
Yep.
I think you even mentioned, even asking questions, does your family come by and see you? And then if we can't, and then we find out, do you attend church anywhere? Does your pastor, do your elders of your flock that you attend, do they even know? And so what we're doing, we're connecting families, communities, churches, basically back in that family's life. And then I'll even say the other part is really helping the PCP. I think a lot of times PCPs might be a little afraid of us because they think we're taking their patient, but we're really trying to just take that patient, handhold them from their hospital discharge back to their office within that 30 days.
Yep.
And a lot of primary cares, once they understand what we do and we're not trying to take their patients away from them, they see, wow, this is a great need, and they are helping me get that patient back in my office.
Yeah, well, not only that, it's really hard because we do try, and we try to encourage all of our patients to come out of facilities. We need you to see your PCP in the next 7 to 10 days.
Yes.
Ideally faster. It's really hard for a couple of different reasons. One, there may not be an opening on the schedule. They do try to accommodate that for sure. Most practice as well. But two, it's also, these are typically homebound people. right? They're just coming out of a hospital. We talked earlier about the level of frailty that, when they're coming back home.
Sure.
So getting them to be able to transfer in and out of a car, go sit in a car for 30 minutes across, Dallas, Fort Worth traffic, getting out of the car, sitting in a waiting room, and then go seeing the doctor. Like that is a whole event that will take them 2 or 3 hours on someone who's already clearly wiped out because of what's happened to them that led them to the hospital and then the hospital stay itself. And so I think that's where there's a ton of value in having a house call transitional care, because even it's an adjunct, it's a help to the PCP and it's a help to the patient and the family, where this whole transitional idea to just going back to the PCP's office in those first 7 to 10 days is really difficult. And I'll go back to again, and the house is still invisible to the PCP. We don't know how effective they really are. Now, for a lot of these patients, we're on them too. There's a lot of home health folks out there. Hopefully the nurses are also looking into I know that we're doing medication reviews, but are they also making sure we're managing those well? Are we taking those medications? So having eyeballs in there to help with that is crucial.
Yeah, absolutely. And the part about the primary care, and I always talk to some patients this way: when you go see your primary care, you're fairly cleaned up, and you're ready to go see your primary care. Us being able to be in the home, we get to see everything, and their living conditions.
Oh yeah.
Everything. We're so we're checking to see if they have the food, and so that information, that social determinants, we're able to give back to the primary care.
Yep.
So it's like Segue's that portal for that primary care to see their patient through our eyes into the patient's home and really understand some critical issues that could be driving some poor behaviors.
Totally. Yes. And so to be a little bit less frank, I patients will sometimes not tell the truth to a primary care doctor. It's really hard to hide that at home, right? Yes. And so, when we talk about like levels of frailty and people needing, they are desperate to maintain. It's a scary. I'm not there yet. I can imagine how it will feel to start losing my safety and my independence. And so the last person I want to know that I had a fall 3 weeks ago is my primary care doctor, who's going to go, "Yep, that's your third one in a year. Yeah. You can't live at home anymore, and you definitely can't be driving." So I'm going to lie my butt off when I go see my PCP and go, "Yeah, I'm good."
Yes.
Right. And so it's a little harder to hide some of those things at home.
Yeah. I did primary care for a long time and I had no idea.
Yeah.
Like the home environments that you go in, it is a whole new world going into these homes as a provider versus them coming into the office as a provider. And it's like, you see them on, or see them in the office for 15 minutes, but then you go to their home and they're hoarders surrounded by just awful environments. You're like, you are not safe living here. Like this is not good for you. That's no wonder your COPD is flaring up all the time. You're living across the street from a cement plant, it's like there's dust everywhere. Of course you can't breathe. Like this is,
or you realize that the POA support, and I love POAs. They're a huge help for us in the home health world, but they get burnt out too.
Right.
And you don't experience that in a clinic environment like I would being in the home, because I get to hear, the conversation, and I get to hear the exasperation of family members who are trying to help mom and dad, exasperation of family members who are frustrated that mom and dad won't listen to instructions, right? So all those things, those dynamics are really, they're nuanced in the house. It's just different from a clinic. And I'm a big fan of having, this transitional care piece, physician led in the home, especially in that first 30 days. Now you guys are you're just there for the first 30. Is that right? Does it ever extend beyond that?
It can.
It can.
Yeah.
Case by
leave
case.
it up to the nurse practitioners.
Okay.
Again, because we're not trying to be their PCPs.
Yeah.
We really want them to get connected back to their primary care, but there's some who don't. And so therefore we'll keep them on for a little bit longer.
Yeah. I'm just imagining scenarios where if I'm really sick and I got CHF or COPD, it may take me longer than 30 days where I feel comfortable getting out of the house to go see my primary care doctor. So that's what I was asking.
Yeah. Or some VA patients, they tend to be a little bit more difficult to get back in to see their PCP.
Oh yeah, for sure.
So we try to fill that gap there too. And it usually goes longer than the 30 days, but there's instances like that.
Yeah.
Mm-hmm.
How does somebody get involved in? I know the easy is you go to a hospital where you guys are embedded, and then the case managers are helping to kind of connect you guys there. I know there's rehab hospitals you guys work with as well. So you guys don't have care coordination folks there, correct?
No.
Right.
Just in the acute care hospitals.
Yeah.
And there's also the acute care hospitals that you might not have, like they're in your target area, but you may not have a care transitions person. I keep saying care coordinations person there. If there was a family member or there's a home health like me that felt like, hey, I feel like you guys are necessary on a couple of these cases, how would somebody find more information about you guys and get connected?
Call Amanda.
Yes. So I would be their point of contact. They can find my information on the website for seguehealthcare.com. We have all of our contacts listed. All the care coordinators are listed as well.
Oh, okay. Good. Okay. And so can a family member request an order to be sent with you guys? So it doesn't necessarily have to come from the hospital. I can call my case manager and say, hey, I'd really like for Segue Health to come out and work with me, for that first 30 days.
If they know who we are, we can certainly be able to do that. But a lot of referrals come from home health, from folks like yourself, because we get to partner. Having a nurse practitioner and a nurse working together, and then with PT and OT and everything else that can go along with that, it's very helpful out there in the world. And then for rehabs and SNFs, when the patient gets discharged out of the hospital and they go to a rehab, they're there 10, 12 days or so, they're still on the hook for that 30 days.
That's right.
So that's how we partner, and why we like to partner with rehabs and skilled nursing facilities, so that we can pick that patient up and finish out that 30 days and help them reduce their readmission rate with the hospital as well.
Yeah, there you go. And just like Sarah was saying earlier about the medication, like the medications have now changed again.
Mm-hmm.
Yes.
So they were one set of meds at home. Then there are another set of meds, because now there's something new at the acute care hospital. And now I'm going to rehab, and I got another bag of meds. I can't tell you how many times I'll go see patients. They're like, so Brian, I have 3 bags of meds. Which one am I taking?
It's all these push packs, that they come home with, and then they got all these bottles, and they're everywhere.
They are terribly confused when they come out. And they're usually, I'm so thankful for the rehab hospitals here. We have some amazing ones here, and they're great. But there's still some confusion when they get back home, because now it's like, okay, now I'm on my own. There's nobody helping to drive this care. They may have a home health out there, but there's still question marks on. And so, how fast are you guys to a patient's home after discharge?
Our goal is to be in the home within about 48 hours post discharge. Okay, and that's either out of a SNF or a rehab as well. We're trying to get in there. If we can get to see the patients early on out of the hospital, especially for your CHF patients, we'd like to try to be there, within 24 hours.
Okay. Is there anything else I did not ask or address that you wanted to get out?
Let me just wrap it up from our side. I know we're probably getting close to time, but Segue is a little different company than most, because we are a faith-based organization, and even outside of the ministry that we get to do here locally, we also get to expand our ministry outside of the country. We get to have mission trips for our nurse practitioners very often, somewhere 4 to 5 times a year, and that's down in Belize and. We went to Kenya. We go to Kenya. Brazil is coming up. So we get to send a team of nurse practitioners worldwide to do medical missions, and then we get an opportunity to preach and share Christ even worldwide. So
I love that.
So not only do we do it here locally, we also do it on a global scale as well.
That's incredible.
Pretty cool.
Yeah, that's very awesome.
Yeah.
Very good. Well, thank you guys so much for joining me today. It's been really helpful to kind of understand how this process works, particularly diagnoses, and why it's important to have a team approach at the home site as well.
Yeah, thank you for having us, Brian.
Thank you.
Thank you.